Greetings, everyone. My name is Jean-Pierre Kikens, and I'm very pleased to welcome for this interview Dr. Brian Tyson. Welcome, Doctor.
Thank you.
Dr. Brian Tyson is a medical doctor in Southern California in El Centro. He's a graduate from the University of Loma Linda in California and of the Caribbean School of Medicine in St. Martin. He has 14 years of experience as a family medicine specialist. Dr. Tyson was one of the first medical doctors in the US to be proactive with the early treatment of patients suffering from COVID-19. Despite many hurdles, he started providing such treatment since March. He and his team have treated some 1,700 patients so far, this without a single reported death from COVID-19. So the first question I will ask you simply, can you tell us briefly your story, your involvement in treating COVID-19, especially in the early days?
Yeah, it was quite a windfall out here in the Imperial County, which geographically, if you're not familiar, we sit on the border between the US and Mexico border, just outside the city of Mexicali. Back in January, when we first started hearing reports of a SARS-like virus from China, we were concerned. We were very proactive. I follow the news very well. And I had actually taken care of some of the SARS of 2003 when I was in residency. During that time, those patients seemed to be extremely sick. Having my own urgent care that we started out here, I wanted to make sure that we were aware of the symptoms, the treatment, anything that was available to start to be able to recognize it when it came to the Imperial Valley. We have a high migrant population. We got a lot of people who cross back and forth to the Mexico border. We have an international airport here for the military. We take care of the border patrol, patrol agents, customs. So we knew we were going to see it. We just didn't know when we were going to see it. When the news broke in February, I want to say late February, early March, of cases going on in New York, I actually got a call from my daughter's music manager, Gary Salzman, who passed away in March from COVID-19. He called me, saying that he thought he got this virus. He was wondering if there was any treatment available. We had been looking at some of the studies that had come out of France on the initial SARS virus. We looked at the 2005 study on chloroquine used for SARS virus and how it showed that it was effective. We tried to get him a hydroxychloroquine and zinc and Zithromax prescription out in New York. His practitioner, his family doctor, said that they're only giving it out at the hospital. I told Gary to go to the hospital. He said, I just got released from the emergency department. They said I wasn't sick enough to get the medication. He said he wasn't even sick enough to get tested at that time. He stayed home for 2 days. We tried to get a prescription written for him out here. There was kind of a freeze on the hydroxychloroquine at that time. 3 days later, was actually able to get a prescription. It was going to FedEx it to him, when he called me from the hospital saying he went back and that he's being admitted. We talked, we tried to get his treating physicians in the hospital to start him on the regimen, which I don't believe they did. And then the last I heard from him, he was on a ventilator and he died about 2 weeks later. I knew at that point that we were going to be in for a struggle out here because of the demographics, because of our resources. So again, I did a lot of the research on it. We ended up taking some precautions with PPE. I talked to our local pharmacist, John Teague, who owns a pharmacy here. And we worked out a deal where if I can prove that these patients were positive, that he agreed that he would dispense the medication for us. We started seeing patients testing positive in a sense where I had serology tests as well as chest x-ray. We had to devise a way to test these patients. When the patients would present to the emergency or urgent care, how are we going to know if they had COVID-19 or not? The test kits that we saw coming out through the ID Now system from Abbott, we actually had the machine in our office, but we couldn't get the test kits for it. The public health department didn't have the nasal swabs. They didn't have the resources to do nasal swabs. The two local hospitals, I think, only had 10 to 12 swabs total in each hospital. So they were only testing those who were really sick and admitted to ICU. We kind of felt like we needed to do something. So I decided to start calling around, and I found a laboratory in Orange County that was shipping in bulk. I think they shipped in 50,000 serology test kits that tested for the IgM and IgG from Korea. So we were able to get a part of that deal. It cost us a ton of money at the time. In the first, I would say, month of testing, we probably spent about $250,000. We took the serology tests. We evaluated every patient that came in through the door. If they had respiratory symptoms, we also did a chest x-ray. And we started to notice that our IgM patients with the positive chest x-ray, those patients were truly positive with COVID-19. We had a couple of patients who presented real early and didn't get put on treatment because they were so sick, but they got sent to the hospital and confirmed that, yes, that PCR was positive and went along with what we were looking at on chest x-ray. So we basically developed a protocol here where patients would present, we get a history of their symptoms, we do an exam, we do a serology test, we were doing chest x-rays, and then in mid-May, we ended up getting the nasal swab availability out here. We had 2 labs that we were using that we can do send-out labs to. So we would swab them and we would send them to the lab. But again, the problem is we were seeing a 4 to even 10 in at the peak, up to 12-day turnaround on trying to get those swab results. And that was despite all efforts through public health, the state, local governments, labs, Quest, LabCorp, all the main players, and we just couldn't get the turnaround time that we needed. So we really relied on symptom presentation and the chest x-ray that really showed us, yes, these patients have COVID-19, and we were very aggressive knowing the lag time on the test results. So if a patient presented with COVID-like symptoms, especially with any respiratory symptoms, we started them on the triple therapy. We started with hydroxychloroquine using the 400 milligrams twice a day for the first day, and then 200 milligrams 3 times a day for the next 4 days for a 5-day treatment. We combined that with the Z-Pak, which is a 5-day treatment, or doxycycline, which was 100 milligrams twice a day for 7 days. And we always gave them the zinc of 220 milligrams twice a day for 7 days. There were periods of time when one drug wouldn't be available, either Zithromax or zinc. We did do some substitutions with Zicam and Airborne to get the zinc component in there. But again, we treated early. Those who had pulse ox of less than 95, so we're talking 94, and we've had patients all the way down to 86, and a positive chest x-ray, we would then call them back every 2 days until we saw improvement. So we had nurses here, our LVNs, our RNs would call and check on these patients. How are you doing on the medication? Are you tolerating it? well or not. The biggest complaint we heard was the GI upset. A lot of patients had diarrhea, some of them had some stomach issues, but that was pretty much the most of it. We didn't have any cardiac complications, thank God. With all the talk of the quote cardiac toxicity, we did not see that. Those heart patients that we thought that may have had a predisposition for arrhythmias or QT prolongation, we would use the doxycycline as opposed to the zithromax. Some of those got baseline EKGs, anyone with a true cardiac history, stenting, heart failure, or if they were on medications such as metoprolol or amiodarone, we wanted to make sure very clear that those patients got closely monitored. Throughout the whole thing, everybody was also told you're going to come back to the emergency or to our urgent care in 7 days. We always checked on them for repeat chest x-rays and wanted to make sure. And then at 14 days, we would do their clearance if symptoms were alleviated, or if they needed to continue with isolation, we would write those isolation orders for them as well. During that whole time, again, from March all the way through now, we've tested probably now 17,000 patients here. We've had over 1,700 positive results. Our mortality rate is, like I said, 0. We've had 1 hospitalization for 4 days. But other than that, we've seen extremely good results with everything that we've been doing here. We've been keeping our data from day one because there was some initial backlash and pushback from both the local emergency departments as well as the public health department, who didn't like us using serology tests. There was that whole disclaimer that you can't diagnose COVID on based on a serology test. We told them we don't use that for a diagnostic purpose, but we use it as a diagnostic aid. Again, we see every single patient who walked through the door. We would use that serology test to confirm or help us along in the suspicion when we're looking at their chest x-ray. The chest x-ray was pretty classic. You saw ground glass opacities, you saw patchy infiltrates bilaterally, and we always saw a low pulse ox. Interesting was one of the vital signs that we're all been taught to use, which is the temperature. We did not see temperature elevations in very many of these 1,700 patients. I would say that the temperature elevation was really close to maybe 15 to 20%. Is all that would present those patients that were presenting with an elevated temperature. But pulse ox was a key. A dry cough was a key, and the loss of taste and smell was another key indicator for symptomatology on presentation. So due to the backlash that we were getting, we started creating a spreadsheet where we kept track of every single positive patient. The public health initially didn't want our data, so they weren't even including our positive cases in the numbers. I was told that even a chest x-ray is not a confirmatory test. And when I just had this discussion with Dr. Monday from our public health department, I asked him, well, what confirmatory test can you provide me? And the answer was, well, send them to the ER. Well, I said the ER is only doing testing on the patients who were admitted. So if you weren't admitted, you weren't tested. And if you weren't tested, then you're not positive. So despite the positive rate out here being almost 12,000, it probably was 3 to 4 times that, because we didn't have the outpatient testing available during the peak of the pandemic out here. We have 190,000 patients here in the Imperial Valley, but we also have 1.5 million people just on the other side of the border in Mexicali. So when you saw the New York Times broke the story on El Centro Hospital and how overrun they were and how we were having to fly out people to San Diego every day, we were getting a huge influx of patients from Mexicali. That was a true state of emergency out here. The National Guard didn't show up until June, okay? So June, so March, April, May, June, finally the National Guard said, it lands in town. But that whole time we've been left out here on an island. So we had to figure out what to do. We started from testing outside with, pop-up canopy tents to basically converting a carport into an outdoor triage evaluation station. That's how complex things got for us out here to be able to handle the numbers. I mean, there were days when I had 300 people waiting in a parking lot to be tested. It was absolute pandemonium out here during that whole time.
So maybe it's amazing what you are saying. Maybe to clarify, how did you hear about that treatment? How did you get precisely that treatment that early in the epidemic?
So it was a combination of what I was hearing and what we studied from what was coming out of France and Germany, along with a colleague of mine, Dr. George Fareed. And Dr. Fareed is a Harvard graduate. He was a academic professor at UCLA. He's a virologist as well. And when we started having discussions, because he works here on Sundays, so we started getting a game plan on what we were going to do. He actually knows Dr. Zelenko. He knows Dr. Harvey Reich, and he had conversations in his academic circle that we were able to come up with this initial treatment. And we were ready to go from day one.
That's amazing. And so you were providing that treatment, and just to repeat what you mentioned, you had only one hospitalization out of the 1,700 patients?
That is correct.
And that person was released from hospital shortly after?
4 days later.
And the level of success you had, did it grab the attention from the state level health authorities?
Actually, no. We got no attention out here for quite some time. It wasn't until the National Guard got here in June that the state started to pay attention to what we were doing. The CDC came down with the state to try to figure out what was going on with the numbers out here, because the surveillance was really poor. The data was very poor. When they talked to us, because they were finding out that there were really only 2 centers out here testing during this whole time, they came to us and we showed them our spreadsheet, and we showed them everything that we had been doing, all of the employers and companies out here that we were screening for and getting off work or back to work, and how to do the surveillance for, example, our Brawley beef packing plant, the Border Patrol, and the Customs Office, the Sheriff's Department, the correction facilities. How are they monitoring all of those things? And the reality was they weren't. When they came to us, we actually had that data. And so we turned that over to the CDC and the state. And then at that time is when the public health finally recognized, wow, these guys are doing amazing work over here. And that's what's led to the conversations of recent. But again, we're talking end of June into July, and we're now finishing up the month of September now into October. But it was very interesting.
So your patients are from corporations, they are employees, mostly migrant?
Yeah, so it's a combination. Yeah, I mean, so we're a huge farming agriculture industry out here. So there's a lot of migrant farmers out here and field workers. But then we also have the Spreckle sugar plant. We've got the Brawley beef, which does a lot of the beef cattle. We've got the cattle feed out here. And then you've got the military correction facilities. We have 2 detention centers. We have an ICE facility, and then you have all the Border Patrol and all of the customs that work out here.
And were there other medical doctors following the same treatment as you in the vicinity? Where did the
And
word spread?
yeah. I mean, so initially it was weird. It was interesting because initially everybody out here was following along the same guidelines because we know everyone. You know, it's a small community, so all the doctors know each other, and everybody was doing was following the treatment. Patients were doing well. People were getting what they needed. It wasn't until that falsified Lancet study that came out that showed, hydroxychloroquine was shown to be ineffective and that could cause cardiac toxicity. And when the FDA pulled the emergency authorization use, then I would say half the community or even 3/4 of the community out here stopped prescribing hydroxychloroquine. Even though the Lancet retracted the article, and even though they know that they were using 4 times the normal dose of hydroxychloroquine in that study, the providers never got back on board because the FDA has not gotten back on board. I think if tomorrow the emergency authorization use was then granted again, that more physicians would use it. But it's that retraction that has got a lot of the physicians scared to go back and use the medication.
So can you explain what were they scared about? Was it about their license, about the ability to operate? Because, and then my second obvious question is what kind of mortality you have in your area without treatment?
Yeah, so I think a lot of it was we got some threatening letters from the California Medical Association that there's some worry that there may be some backlash on our licensing. What would the DEA look at it as like? And at even to this day, we still don't have an alternative treatment. So it's not like they're saying, oh, if you don't use this, you should be using this. The reality is if you don't use hydroxychloroquine, then basically you're just giving them the zinc, the Zithromax or doxycycline and vitamin D and vitamin C and hoping these patients do better. I don't know what the outcomes of their patients are, but I know the outcomes of my patients. And if what I'm doing is working, I'm not going to change it. To me, that's proven observational studies, with numbers that are not coincidental under any circumstance. You can't tell me 1,700 patients who test positive it's a coincidence that none of them have died. It's not a coincidence that none of them have been hospitalized. That's not coincidental.
Okay, that prompts me to the question, what do you tell the people who say you need to basically give a placebo to half the patients to prove that it works?
Yeah, and I would say no. The proof is in the treatment. The proof is in the treatment. And we don't do randomized controlled trials, on most drugs that we pass here in the United States. You can do a randomized comparison trial when you have alternative treatments for, say, antibiotics. This antibiotic versus that antibiotic. But you're not going to take somebody with pneumonia and give them a placebo and then give somebody antibiotics and say, oh, look, see, this person died from pneumonia because they didn't get the antibiotic. We're not going to do that. We're playing with a deadly illness in patients who have the highest risk. And I've had patients up to 88 and 90 years old, okay? The highest risk group of patients. We gave them treatment and they survived. To me, that's all the proof I need.
I interviewed recently Professor Perron from France and also Professor Borodi from Australia, and both share exactly the same view. How do you explain that the US authorities don't share the same view?
I don't know. Honestly, I think There's a political play back and forth with some of these governors because some states it's not a problem, in other states it is a problem. In one state, they tried to make it illegal. I believe in the state of Ohio, at one point, the governor deemed giving hydroxychloroquine was illegal. But these are people who don't have medical degrees. These are people who aren't treating patients every day. These are people who don't have people showing up in your office and saying, hey, my dad is sick, or my grandfather is sick, or I'm sick. What can you do to help me, doc? I hear this treatment is working. Can you prescribe it for me? Well, in that situation, patient consent and patient willingness and that patient's right to try, which we've already passed that law in this country, they should have the ability to try the medication. It's informed consent. It's not being forced upon anyone. It's not saying you have to take this medication. These patients want this drug. This drug has been proven to work. I am a licensed physician, and I should be able to prescribe it. We give out 4 to 6 million prescriptions of hydroxychloroquine every year in the United States for patients with rheumatoid arthritis and lupus and Sjogren's syndrome, right? Ankylosing spondylitis, all of these autoimmune disorders. The population that everybody thought was going to be wiped out with COVID, but yet they're all survived. They take the medication. They're not dying from drug overdoses. They're not dying from cardiac arrhythmias. You know, when you look at the labeling of hydroxychloroquine, it does not even come with a black box warning. Tell me a drug that is so cardiotoxic, why doesn't it have a black box warning? Why is it sold over the counter in many countries, including Africa? You know, I believe we have more deaths from Tylenol, acetaminophen, every year than we do from hydroxychloroquine arrhythmias. But yet, nobody's pulled Tylenol off the market.
I saw a recent interview of the Secretary of Health from California, and basically he dismisses hydroxychloroquine. Didn't the word get to him that something was happening in your community?
You would think. I mean, it wasn't until the New York Times broke the story that we got any attention. It wasn't until it was in the national media, not the state media, not even the local media. It wasn't until the national media that we got attention. Now, remember, that's also around the same time when all of these riots started breaking out, and that seemed to be the main media's direction. They were more concerned about, you know, the protesting than they were about people being sick and getting resources and covering stories that meant something. You know, every time that we would post something on social media, it would get taken down. Why is our social media being taken down? Why are videos being taken down when we're the doctors? We're the ones seeing the patients. What does a social media company have to do with medicine? How are they able to take down when I say, hey, hydroxychloroquine is working, and the next day my post is deleted? Why is that? Who controls that? The medical board? The medical board doesn't control that. You know, that's a political game to me. And that's where politics and medicine have no business mixing. I don't care if you're Democrat, Republican, Independent, Green Party, I don't care. Keep politics out of medicine. Let us physicians do our job. That's what's important. If I'm seeing 16,000 people show up to my urgent care and I say, hey, this is what we're seeing on chest x-ray, this is what we're doing for treatment, and it works, you would think that that's what people would want to hear, especially in the middle of a pandemic.
Of course. Did you hear some patients having some questions or fears regarding hydroxychloroquine because of what they heard in the media?
Yeah, and some patients would would decline treatment, which is fine. You can decline treatment. You have the right to decline it. Others would ask about it, and I would tell them. And then I've had even patients bring family members back after they got treatment and with another family member say, you need to come see Dr. Tyson because he's going to give you the treatment. We all got better. You're not getting better. You need the medication. Quite the opposite effect out here. And if you look at, our social media page, if you look at, our community, I can tell you that they are thankful that out here we use the medication. They're very, very thankful.
So do the authorities, already see a kind of a decline, comparative decline in mortality compared to other counties, other areas, because of your action?
Absolutely. Our mortality rate out here is only 2.6% of positive cases. And a lot of those cases are the ones that present from either Mexicali or even out of county, because just north of us is San Bernardino County, and there's a little area called Blythe that has a detention center which sits right on the California-Arizona border. They also come down here for treatment because it's a far drive for them. Those patients showing up extremely sick because the marching orders for positive testing was go home for 14 days. Do not leave your house. Anybody in your house that or anybody who's in your house also has to stay home for 14 days. Mandatory quarantine, right? We all heard it. Okay, well, if you have pneumonia or a urinary tract infection or cellulitis, and I send you home for 14 days without any treatment, what's going to happen? You're going to get extremely, extremely sick. Okay, so these patients went home, they tested positive, not here, somewhere else, either the other provider or maybe when the National Guard came. These people were getting positive test results, but they weren't being told what to do in the event the symptoms got worse. When do you go back to the hospital? Or is anybody calling them to check on them? No. They got sick to the point where when they got to the hospital, they ended up in the ICU and on a ventilator. Well, by that time, I don't care what disease process you're talking about. If you're so sick that you're on a ventilator at that point, antibiotics isn't going to save you from sepsis. Okay? Hydroxychloroquine is not going to save you from COVID-19 at that point. ARDS is ARDS, from whether it's acute pancreatitis or overwhelming septic infection, urinary tract infection that's gone into gram-negative sepsis, or COVID-19 or influenza or swine flu, whatever you want to call it. ARDS is ARDS. Once you've reached that point, now it's just, can your body survive it or not? That isn't a treatment-based, that's an inflammatory-based reaction that only time will tell. Those who got treatment early did amazingly well, as proof by our observations here at the urgent care.
Two questions as follow-up on this. The first may be a clarification. When you mentioned the 2.6% of mortality, these are among confirmed and symptomatic cases, I presume?
That is correct. So on our public health, if you look at our public health website, 12,000 positive patients with, I want to say 317 deaths. So when you look at the confirmed positive to the mortality, that's about 2.6%. When you look at New York, they were at like 6.7 or almost 7% of confirmed cases to their mortality rate.
Because just recently, with this huge increase in testing and plenty of false positives, I don't think the case fatality rates mean much any longer.
Yeah, at this point, you're probably correct. But I would still look at the population, community, the severity of illness, which everybody recognizes Imperial Valley severity of illness was extremely high. It was overwhelming our hospitals. And we only had 317 deaths from COVID in a population that serves almost 2 million people. That's unheard of.
Okay. Yeah. Did you feel, did you feel isolated in the sense that you didn't have the support either from the California authorities or the federal authorities?
That is correct. And I sent emails, we made phone calls. We had, again, no PPE support until the end of June. We had no testing support until mid-May. And I called Abbott Pharmaceuticals, their rep, and said, hey, I have a machine. I have the ID Now machine in my office, but I can't get test kits. The federal government and FEMA were using all of those test kits for their sites that they deemed necessary. But at the same time, we had 7 machines in the valley, and we couldn't even get a test. We couldn't get any test kits. I even offered to donate my machine to the public health department, so at least they would have that ability. And the reality is we couldn't get anything out here. I had to take out business loans in excess of $250,000 to take care of this community with no support. Nobody gave me a grant. Nobody came to my door. Nobody dropped off anything, until very recently. We do get a supply of personal protection equipment. I will give them that. In the last 2 months, that has been steadily supplied to us. And now finally, we're getting a lot of the ID Now kits so I can do the rapid testing here and not having to do send-outs. And that has been a change over the last month. But before that, the previous March, April, May, and into June, we had very, very limited support. It was all independent finance and what I can find in either Texas or Orange County, and what I can have flown in from Korea.
Regarding PPE, how were you protecting yourself, or did you get your staff protected if you were lacking the PPE?
Believe it or not, my mom made face masks with interchangeable filters. And we took the N99 HEPA filters, and she would sew those into the masks, and that's what we use for PPE. Yeah. Yes.
And did you do any form of prophylaxis for yourself or your personnel?
We drank tonic water. We did. I would drink tonic water because that was the only thing we can get our hands on. For the initial. In the peak of illness out here, when we were seeing a lot of patients, I will admit I did use hydroxychloroquine once a week. I would take a tablet just for prevention, but that was for the May into June. It was really right after Mother's Day when we saw a huge influx in positive cases.
And you were treating people. You were seeing the patients. It was not
yes.
This
is not virtual. No, we did nothing virtual. No, I'm a hands-on doctor. We were in the middle of it, out in the tent, evaluating patients, getting pulse oximetry, listening to lungs, looking in their throat, understanding. I needed to understand what this illness was.
I did an interview with Professor Varron, who is actually of Mexican origin, but he works in Texas, and he's very much involved in more advanced stages of the disease. But we had this amazing interview that was a few months ago. But he was mentioning that there is a stigma in the community often, and that people are reluctant to show up because they don't want to admit they may have COVID. Did you see that? Did you get people arriving just too late?
We did. Yeah, we did, and there was a lot of patients who were afraid to come because they didn't want to catch COVID, you know. But the way that we set it up was we had a number system. So you would show up in your car, we would deliver the forms to your car, you would fill it out, we would call patients up one by one into the tent, evaluate them, send them back to their car, and then deliver the results to them in their car. If they needed a chest x-ray, we would give them a mask. All of our employees always wore masks. We would bring them directly into the x-ray room, shoot the x-ray, and then send them right back outside. And we would look at the results and we would decide what we were going to do. So we did everything on an individualized plan basis. It took a lot of time. We spent a lot of hours out here. We were working from 12 noon to midnight, sometimes 1 o'clock in the morning. But that's how we did it. So it was basically a number system. We had them numbered. We had time slots for them as they got numbered. And I tell you, we saw some days we saw 200 people. Some days we saw 300 people. It was absolutely pandemonium out here. But as that process got developed, people got more confident, and their anonymity was maintained because they got to stay in their car. So I think that and nobody knew results. It's not like you walk in the emergency department and everybody's waiting in the waiting room. There was the anonymity of, you're in your car, you're isolated, you're with your family members, and nobody knows who's positive or negative at that point.
I guess it was also better from a transmission viewpoint.
Absolutely.
And in terms of the concept of early treatment, do you think that the population, at least the community, got the message that, you better go sooner than later to see the doctor? Because that's a concept that seems to be still ununderstood by many, because the authorities have not explained that. So people, I fear that it's still a message after several months of pandemic that is not yet fully understood by many.
Yeah, and to me, I don't understand that. As a medical community, we know disease progress. Again, we all know that coronavirus, COVID-19, has a flu phase and an inflammatory phase. Okay, we all know that. We all know also that to treat influenza with Tamiflu, you have to treat it early. So the same concept, just a different virus. So it makes no sense to me to say, why wait when we know you got to treat viral infections early when you're using, quote, antivirals. We know hydroxychloroquine is a potent antiviral. We know Zithromax is a potent antiviral. The community out here saw, and this is typical of our demographic, if you go to the hospital, you're going to die. That's what they saw. If you ended up in the hospital, you weren't going to make it. But if you went to go see Dr. Tyson, you can survive. And that's why we saw patients early. Go there before you end up in the hospital, because if you end up in the hospital, you're going to die. That was the concept out here. And I think that's why we were allowed to treat so many patients soon.
Interesting. Now, in case somebody would show up not very, very early on, maybe 5-10 days after the symptoms, were you doing more than the tritherapy of hydroxychloroquine, Zithromax, and zinc?
Yeah, so if we saw severe illness on chest x-ray, we had probably a good 10 to 12 patients show up with pulse ox in the 80s. We would either give them IV treatment to start, which would include Decadron 4 milligrams, dexamethasone. We would also use the inhaled nebulized Pulmicort we would send them home with. We sent some patients home even with oxygen tanks. so that they would get the supplemental oxygen they needed. Again, those patients made the decision not to go to the hospital. So rather than just letting them go home, we gave them the resources to at least do the best we could in hopes that the virus would turn around. And surprisingly, those patients 2 days later, when we called on them, they were off oxygen, they were improving their symptoms. Sometimes we would extend the hydroxychloroquine for another 5 days. And in all of those patients, they made a full recovery.
That's amazing, because in many places that would be considered a patient that who needs to go to hospital.
Absolutely, and that's what we would tell them. But the demographics we're at, no, I'm not going to the hospital. You die if you go to the hospital. So they refused, and I had these patients outright say, I'm not going to the hospital. I want the treatment because I don't know if they're going to give me the treatment in the hospital. And that was a concern for a lot of patients out here too. So we made sure they got the treatment. We gave them the nebulized budesonide. We gave them the IV or IM Decadron. We gave them a hydroxychloroquine and either zinc or doxycycline and Zithromax. And these patients did well. They absolutely did well.
Amazing. The place I heard about similar approaches in Brazil is in Brazil. People also were afraid of going to the hospital, and then the outpatient treatment became much beyond the hydroxychloroquine and Zithromax and zinc. They also are using ivermectin very frequently there. But it was really amazing how this fear of going to the hospital, while the logic from a normal person is to say, oh, I'm going to be well treated in the hospital. The hospital is a better place to be than being alone home with my medications.
Yes, absolutely. It was very weird, but again, what do you do? When you have the patient sitting in front of you, and they said, no, that's not what we're not going to go there, So, again, I'm like, okay, well, we have to do something, so, we started this, and like I said, we had people, I had LVNs here, I had RNs here, I've got scribes who are physicians from Mexicali, and they're calling patients, they're checking on patients, how are you doing? How are your symptoms? How's the breathing? Are you getting better? Are you getting worse? I mean, we had a lot of follow-up on all of these patients to make sure that they were doing well. And I think that was another thing that separated us from everyone else.
Amazing. The question of the high-risk patients, especially old people in nursing homes, how was it handled in your community? And I understand Dr. Farid was also involved in treating in nursing homes.
Yeah, so Dr. Farid is the medical director of one of our nursing homes here, and there's only 2 of them. And they started with a surveillance program because of what happened in New York. When all of those patients went back to the nursing home and so many of them died, there was that red flag had already been raised by the time the cases got out here. So there was a surveillance program at the nursing homes, which they were able to get testing, but it wasn't until a little bit later, but they were able to get testing just for nursing home patients. Dr. Farid had 31 patients in the nursing home test positive, but he started them on treatment, and he started them on treatment early. And of those 31, 29 survived. There were only 2 deaths out of the 31 nursing home patients. That is also, to me, a statistical significance when you're looking at how many nursing home deaths there were across the nation because of COVID-19.
Yeah, and it's amazing, and I saw that French study where they did a similar approach in a elderly home, and they had a similar treatment, and they got also a much reduced mortality in the nursing home. It was, and there the
Yeah.
average age was 86, I think, average.
Mhm. Yeah.
So, what is the situation now? How do you, in terms of, how do you think this is going to evolve? I'm in the Montreal area. It's the second wave in Canada, and I guess it's coming in New York. I heard that Dr. Zelenko was mentioning there is a spike now in his community in northern New York. But how do you see the situation in Southern California?
We've seen a big drop in cases out here. We have not seen a second wave. We're paying real close attention to whether that's going to happen or not. We are also, believe it or not, what we're seeing is a less severe illness at this point as well. In the end of May into June, we had a lot of patients presenting with what we would deem as severe symptoms. At this point, most of them are pretty mild. It seems to be maybe this is just a different coronavirus that we're seeing that's also testing positive. With the testing that we're using, we know there's a lot of false positives, but the severity seems to be more along the lines of an upper respiratory viral infection, just like the common cold, as opposed to the severity of respiratory symptoms, the shortness of breath, the chest pain, and the pneumonia on chest x-ray.
In France, they did some genomic analysis, and they could basically visualize that the strains of the virus were pretty different. And they also observed reduced kind of potency of the virus and reduce kind of severity of the symptoms. Do you get any form of scientific input about the strains that are affecting your community?
No, we haven't gotten any feedback on that. We are a CDC surveillance site, so we do send state swabs up to Sacramento. They do have the data. I don't know if they're testing the strains up there or not. I don't know if they're isolating the genomes out or not and seeing if anything's changed. But that is a good question, and I don't have an answer to that.
And your observations, have you corroborated them with what other medical doctors see about this potency of the virus?
I'm hoping, and I think that that's going to be the next phase, is we really need to start looking at that severity. I think out here they're still basically catching up with the data from the first wave. We had been in complete lockdown all the way up until I think 2 weeks ago, where we barely got out of stage 5 or wherever they're at, on that spectrum, where they're just starting to open up businesses. They're just starting to open up restaurants for outdoor seating. So we hadn't even gotten past the first phase to even look at the severity of illness. I think they're still just counting cases and trying to figure out who's sick and who's not.
Okay, so it looks like the federal policy regarding COVID in the US is a lot of remdesivir and then very quickly available vaccines, and HCQ is a word that seems that nobody will dare pronouncing on the governmental side before the election. That's my reading. But how do you see the vaccine playing a role once it is available, if it is available, and which vaccine?
Well, I mean, I think we really need to look at age groups, and we need to look at high-risk groups versus low-risk groups. I do know from the research initially done on the SARS vaccine from 2003 that they were developing in 2005 and 2008, that a lot of those vaccines had inflammatory response problems to those vaccines. Okay, their number one concern was the safety of the vaccine. So that would also be my concern. Fast tracking a vaccine, we got to make sure that it's safe. Number one. Number two is identify the high risk groups that would need a vaccine. I'm not for vaccinating, anyone under the age of 19 for COVID-19 when you have a 99.997% chance of survival. To me, doesn't warrant a vaccine. If we want to look at the 75 and over population, that high risk group with diabetes and heart disease and hypertension, yeah, probably start there and see how the vaccine goes. If they can stay protected and it seems to work, then, if you get a couple of years under your belt and you can show that it's safe to use, then maybe you extend it down to 65, down to 55, and then maybe over 50. But anyone under the age of 50, I do not believe needs a vaccine based on the statistics for mortality. We're not going to get a vaccine for every common cold virus. We're not going to get a vaccine for every bacterial infection we get. We're going to look at which viruses can you vaccinate for. That's going to lead to long-term eradication. But it kind of I kind of go back and forth with the influenza vaccine. Sometimes it works, sometimes it doesn't. But we're vaccinating over and over and over, and what are the long-term effects of it? And how do you know that an anaphylactic reaction is not going to prevent a kid from getting other necessary vaccines because they're getting a vaccine that they don't need? That's just my 2 cents on it.
Yeah, I think there will, from what I see here, there will kind of, for most people, it will be a rush on the vaccine because of it will alleviate the fear. People don't understand the ins and outs, and so there will be a rush. And I think in Canada, for example, they have ordered, the number of doses they have ordered is crazy. I mean, it's 3 doses per capita or something like that. So there is no stratification whatsoever of I was talking to Professor Perron about this question, and my point was this one. The people on which the vaccine is being tested are very healthy people. These are volunteers right now. And one witnesses already severe adverse effect on relatively small numbers.
Yes.
If the vaccine is being given to only high-risk people, isn't the vaccine potentially becoming more dangerous than the disease?
It's possible. It's possible. And again, that's why I am very cautious to say, yes, the vaccine is going to come out and it's going to be a wonderful thing. I don't know. Only time will tell. But what I will say, though, is we can't just go and vaccinate everyone and see what happens. Because if there is a problem and it becomes worse than the actual virus, then what? Then now you have kids and young adults having long-term complications who otherwise wouldn't be having long-term complications or short-term complications. I don't like rushing anything in medicine. We're always told, don't rush. Take your time, think things through, let common sense be common, do your research, base things on evidence. We've lost that touch with the government at this time. They claim to be science-based, but they're not using science when it comes to making decisions. Recently, I think there's been now over 30 hydroxychloroquine trials all over the world that has shown a reduction in mortality. If you're not going to look at those numbers, then you're not a scientist and you are not following science. You're following your own personal agenda, and personal agendas have no business in medicine.
I think it's an essential message. I think there are people with a variety of level of information on this, but very concretely, I know it's very politicized in the US, but I guess either you are a Democrat or a Republican, but if you have COVID, you better show up to a clinic. That would be the message, isn't it? And early.
Yeah, absolutely. I mean, absolutely. That's what I mean. You know, they when COVID first came out, they said COVID doesn't have a political affiliation. Well, let's leave it at that. Let's let this not have a political affiliation, and let's do the right thing. If the drug works, let's use the drug. You know, my final stay in all of this is, I always tell people, if I'm wrong, people are still going to die. If I'm right, we can save thousands and thousands of lives. What's there to lose in trying? What's there to lose?